I have to be honest, after reading these reports from the Carlot Addiction Treatment Report and the Hospital Psychiatry Report, I'm a little paranoid.
I can see why. It's the kind of thing that makes you question everything.
Right. We always think of health in these two separate buckets. You've
Yeah.
got your physical health over here, a broken bone, whatever, and then your mental health way over there.
Different doctors, different buildings.
Exactly. But these articles, they make that line seem like a total hallucination. We're talking about like liver problems causing psychosis.
Or tumors that look exactly like schizophrenia.
It's a medical detective story where every single clue points you in the wrong direction.
It really is. And the thing is, the stakes in that story are incredibly high.
Because if you're treating the brain when the real problem is, say, the immune system.
You're not just missing the diagnosis.
Yeah.
You could be doing real, lasting harm to the patient.
Okay, so let's start with the things that honestly terrified me the most. The great imitators. These are the physical diseases that show up wearing a mental illness costume. And the one that just blew my mind was syphilis. I thought that was, a history book thing.
It feels like it should be, doesn't it?
Yep.
But it is very much still with us. And there's a reason we call it the original great imitator.
But isn't that just, sores?
Well, that's how it starts. Primary stage, you get sores, maybe a rash on your palms and feet later. But the bacteria is playing the long game.
The long game.
The sources talk about neurosyphilis. This is the tertiary stage. It can pop up decades after the first infection.
Wait, decades? So you could catch it in college, completely forget, and then in your 50s just go crazy?
Essentially, yes. The bacteria gets into the nervous system. It can cause mania, massive memory loss.
So it looks like dementia.
Or severe bipolar disorder. And you're sitting in a psychiatrist's office getting meds for mania while the bacteria is literally eating away at your nervous system.
Wow. And the fixes?
Penicillin. If you catch it, penicillin is still the magic bullet.
Wow.
But if you spend 5 years treating it as the wrong thing, that brain damage can become permanent.
Okay, so check for the ancient diseases. Got it. But it's not just the old stuff. The reports also get into Lyme disease.
Right, and we all think of the bullseye rash, the joint pain.
The outdoorsy connection.
But the bacteria, Borrelia, it loves the central nervous system. So early on, you get this profound brain fog. It just looks like depression.
But here's the part that really got me. Post-treatment Lyme disease syndrome. So even after the antibiotics, after the bugs are dead,
You can still have symptoms.
you can still feel crazy.
It's a huge controversy, but for about 10% of patients, yes, they have lingering pain and fatigue. And that chronic physical stress, it eventually rewrites your mental state. It becomes a genuine mood disorder.
So we've got bacteria. What about when the body just attacks itself? I mean, I've heard of lupus, the butterfly rash.
Systemic lupus erythematosus, yeah.
I had no idea it could make you hallucinate.
In severe cases, it's surprisingly common. It causes inflammation everywhere, and that includes the brain. We call it lupus cerebratus.
And it can look just like schizophrenia.
Indistinguishable. A patient can show up with full-blown psychosis, hearing voices, delusions. You have to look at the whole picture. Check the skin, check the joints, run the antibody tests. Because if you treat the immune system, the schizophrenia just fades away.
Speaking of things fading away, this brain on fire scenario, anti-NMDA receptor encephalitis, that is straight out of a horror movie.
It's profound. The body creates antibodies that attack these critical receptors in the brain, the NMDA receptors.
And it's caused by a tumor, but not a brain tumor.
That's the crazy twist. It's often an ovarian teratoma.
I read this, a tumor that can have teeth and hair in it.
It is unsettling, yes. But the immune system sees that neural tissue in the ovary, thinks that's not supposed to be there, and creates an army of antibodies.
And that army goes to the brain.
And attacks the actual brain. Patients go from flu-like symptoms to catatonia and seizures in just a few weeks.
And the cure is just surgery.
You remove the tumor, the antibody factory shuts down, and the mental illness resolves.
Incredible. Okay, one more mimic. Acute intermittent porphyria, AIP. The report says you can treat a psychotic attack with sugar? A bagel.
Carbohydrate loading, yeah.
Yeah.
It sounds almost too simple.
It sounds like something my grandma would say. Have some toast, you'll feel better. But for seizures...
So AIP is a genetic problem with making heme for your blood. When the production line for heme in the liver goes into overdrive, it creates toxic byproducts.
And those toxins poison the nervous system.
Right, causing terrible abdominal pain and psychosis. But that enzyme in the liver is sensitive to glucose. So when you flood the system with sugar
A bagel.
or an IV of glucose, you're chemically telling the liver to shut down the production line. You stop the toxins, you stop the attack.
So going on a keto diet could literally drive you insane if you have this gene.
Fasting is a huge trigger. Precisely.
Okay, so that's all hardware problems, right? Tumors, bacteria, enzymes. But then the report shifts to something that was, even harder for me to wrap my head around. Functional Neurological Disorder, FNFAND.
This is a massive shift in how we think about things.
This is when someone is paralyzed or having seizures, but all the tests are completely normal.
Right. We used to call it hysteria, which is a terrible, outdated term.
Yeah.
The best analogy is a computer. In a stroke, the hardware is fried. You can see it on an MRI.
A broken circuit.
With FND, the hardware is pristine.
Yeah.
The MRI is perfect. But the software is glitching out.
But I have to ask, are they faking it? I feel like that's the first place your mind goes.
No. And that is the absolute most important takeaway. The suffering is real. The symptoms are involuntary. They are not faking.
So how do you prove it? How do you know it's a software glitch and not hidden epilepsy? The report mentioned the distractibility sign.
This is such a clever diagnostic trick. It's all about mental bandwidth. A tremor from Parkinson's, that's a hardware problem. The circuit is broken. It's always on. But a functional tremor needs the brain's attention to exist. It takes up bandwidth.
So you hijack the bandwidth.
You give the patient a complex task. You say, count backward from 100 by sevens.
Which is really hard to do.
It takes focus. And the brain can't maintain the software glitch and do the math at the same time. Suddenly, the tremor just stops.
Yeah.
Or the rhythm changes. That's how you know the hardware is fine.
Wow. And the treatment is just retraining the brain with physical therapy.
Physical therapy that uses distraction. You're essentially debugging the code.
So FND patients are not faking, but some people do fake it, which brings us to factitious disorder.
Right. And this is not malingering, which is faking for some external gain like money or to get out of jail.
This is faking for an internal gain.
They want the sick role. They have a deep psychological need for the care, the attention, that whole identity.
And the profile is fascinating. Often women and often people who work in healthcare.
It makes a kind of sense. To fake a disease well, you have to know how the system works. You have to know the script.
Like the case of Emily, the nurse with low blood sugar hypoglycemia.
Right. She keeps coming in. Her labs show super high insulin. Any doctor would think, okay, she has a tumor in her pancreas, an insulinoma.
But they caught her.
With a biological receipt. When your pancreas makes insulin, it also makes a byproduct called C-peptide.
Okay.
They come out in a 1-to-1 ratio. Think of it like a factory seal on a bottle.
So if my body makes it, it has the seal.
Correct. But the insulin you inject from a vial doesn't have C-peptide. And Emily's labs, her insulin was through the roof, but her C-peptide was flat.
The factory seal was missing.
Proving it came from a syringe, not her pancreas.
God, that must be such a hard conversation to tell someone, we know you're doing this.
You have to use what's called supportive confrontation. You lay out the evidence, not to shame them, but to stop them from getting dangerous, unnecessary surgery, and you try to pivot them to psychiatric care.
Okay, let's pivot ourselves to the last piece of this. We've talked about mimics, but now let's talk about the raw physical toll of substance withdrawal.
Yeah, the Carlisle report really dives into this.
And I feel like we totally underestimate how physical this is, especially with alcohol.
Oh, absolutely. Alcohol withdrawal is the single most dangerous withdrawal syndrome there is. It can kill you.
The timeline is just relentless.
It's a cascade. At 6 hours, you get tremors. At 24 hours, hallucinations can start.
48 hours, seizures.
And then the real nightmare, delirium tremens, the DTEs. Your whole autonomic system just goes haywire. Blood pressure, heart rate, confusion. Without benzodiazepines to calm the brain, the mortality rate is significant.
Now, compare that to cannabis. The story is always, weed isn't addictive.
That story needs a major update. The withdrawal won't kill you, but it's real. Irritability, can't sleep, no appetite, and one really weird symptom.
The dreams.
The return of vivid, bizarre dreams. Cannabis suppresses REM sleep, the dream phase. When you quit, your brain tries to catch up on all that lost REM time. It's called REM rebound.
But the real issue here is the potency, right?
That is the game changer. The report cites studies where daily users are consuming up to 500 milligrams of THC a day. A standard dose to get high is maybe 10 or 20.
500? That's an industrial amount.
But tolerance is massive. So when they stop, the shock to the system is so much more severe than anything we've seen before.
Okay, and finally, opioids. You have to explain precipitated withdrawal to me. It sounds like actual torture.
It can be.
Mm.
And it happens when you're trying to treat the addiction with buprenorphine or Suboxone.
How is that possible?
Okay, so buprenorphine is what we call a partial agonist with high affinity.
Break that down.
Think of the brain's opioid receptor as a light switch with a dimmer. Heroin or fentanyl are full agonists. They crank that dimmer switch up to 100%, blindingly bright.
Got it. Full brightness.
Buprenorphine is a partial agonist. It only turns the lights up to maybe 20%. Enough to stop withdrawal, but not enough to get high.
And the high affinity part.
It means it's super sticky. It grabs onto that receptor much tighter than fentanyl does. So if you take it while fentanyl is still in your system,
It kicks the fentanyl out.
instantly.
Yeah.
The super sticky buprenorphine rips the fentanyl off the receptor. But remember the dimmer switch. You go from 100% brightness to 20% brightness in a split second.
Oh, that drop, that's the withdrawal.
That is instant, severe, full-blown withdrawal, vomiting, panic, pain. It's a nightmare. You have to wait for the person to be in mild withdrawal first, let the lights dim on their own before you introduce the buprenorphine.
Before we finish, there's one last thing. Akathisia. I always thought that just meant, being fidgety, but the report calls it an emergency.
It is an absolute medical emergency. Fidgety doesn't even begin to describe it. It's Greek for inability to sit. But patients describe it as an inner torture, like you want to crawl out of your own skin.
It's a side effect of meds.
Usually antipsychotics that block dopamine. And here's the dangerous loop. A patient gets akathisia, so they start pacing. They look agitated.
And the doctor thinks the psychosis is getting worse.
So they increase the dose of the antipsychotic.
Which is the thing causing the problem.
It's like pouring gasoline on a fire. It gets worse and worse. The feeling is so unbearable, it's highly linked to suicide and aggression.
So what do you do?
You ask. You say, do you feel restless on the inside? And if they do, you lower the dose, or you add a beta blocker like propranolol. It can fix it almost immediately. Just asking that one question can save a life.
We started this saying the line between physical and mental health is blurry, but after all this, I don't think the line exists at all.
It really doesn't. The brain is an organ connected to everything else. A stomachache could be porphyria, anxiety could be a tumor, a seizure could be a software glitch.
It really feels like the big takeaway is you have to stop looking at the symptom and start looking at the whole human.
You'd have to stay curious. You have to be a detective.
So here's a final thought for you to chew on. We talked about those 500 milligram THC doses. We are running a massive, uncontrolled experiment on a generation's brain chemistry.
We have no idea what the long-term effects are.
Exactly. We don't know what the withdrawal profile from that kind of use looks like in 10 or 20 years. The next great imitator could be something we're creating right now.
That is a sobering thought.
Something to think about. Thanks for diving deep with us.
My pleasure.